Welcome everyone to the GSA Momentum discussion, How Where You Live Matters, Geographic Disparities and Life Expectancy at Midlife. My name is Erwin. I'm the AARP Director of Thought Leadership Health, and I'm the moderator for today's session. I want to welcome everyone here, and especially our speakers, and thank them all. Rodney Harrell, who's the AARP Vice President of Family, Home, and Community at the Public Policy Institute. Courtney Lyles, Associate Professor at UCSF in the Division of General Internal Medicine at the Zuckerberg San Francisco General Hospital and Co-Principal Investigator at the UCSF Population Health Data Initiative. Ali Mokdad, Professor of Health Metrics Science in the Institute of Health Metrics and Evaluation, IHME, and Chief Strategy Officer for Population Health at the University of Washington. And Roland Thorpe, Professor at Johns Hopkins Bloomberg School of Public Health, faculty of the Johns Hopkins Center for Health Disparity Solutions, and co-director of the Johns Hopkins Alzheimer's Disease IHME. Thank you all today. Really excited to have this, and I am going to briefly talk about a report that I did. Recently, we released at AARP that talks about how growing geographic and racial disparities inhibit our ability to live longer and healthier. And with that, I actually transition over to the video. Today, you're invited to consider the story of human longevity and how it is also a story of equity. My name is Dr. Erwin, and I'm the Director of Thought Leadership Health at AARP. Since the mid-1800s, we see longevity increasing as measured by the best performing countries, but we see that not everyone has benefited equally. In the US, the place you live can determine how you age. Life expectancy at age 50 describes the age a 50-year-old can expect to live and can be used to measure the healthy longevity of a society. Looking at a map of the United States in 1980, we can see where the best and worst performing counties are located in terms of life expectancy at age 50. As we move forward to 2014, we can see where these disparities have persisted and grown. If you take the top and bottom 1% performing counties in terms of life expectancy from this map and plot the difference, you get this red line. The higher the number, the greater the geographic disparities. In this time period, life expectancy in the best performing counties has increased by 3.2 years more than life expectancy in the worst performing counties. From 1980 to 2014, geographic disparities in life expectancy at age 50 increased by 3.2 years. Racial disparities underline many of the geographic disparities in life expectancy that we find between counties. In 1980, a 50-year-old resident of a Black majority county could expect to live to the age of 76 years. These are counties where the majority of residents, 50% and greater, were Black residents. In 1980, a 50-year-old resident of a county with less than 5% Black residents could expect to live to almost the age of 79. By 2014, both sets of counties experienced gains in life expectancy, but the Black majority counties in blue did not catch up until 2008. It took 28 years to catch up to where the counties which had less than 5% Black residents were in 1980, in purple. Disparities in life expectancy are not unique to the United States. As we respond to the ongoing pandemic, now is the time to work collectively across all sectors of society to expose and address structural inequalities that adversely affect communities of color. It is a matter of life and death. Where you are born and where you live matters as you age. And in the wake of the COVID-19 pandemic, the population health perspective is more important than ever. So I'm going to ask our speakers to describe the work they've done with geographic or racial ethnic disparities and how it has become even more important to understanding and addressing the problems we face with the COVID-19 pandemic. And I'm going to turn over to Rodney. Do you want to go first?
Sure, happy to. And I think you raised a very good question for us to talk about today, Erwin, in that we've got a lot of equity and disparity issues across our country that have been there for decades and even centuries. And so it's studies like this one that help us to understand that they're there. And then it takes approaches like AARP's Livable Communities approach to help to tackle some of the factors behind it. Now, when we talk about livable communities, we try to make sure that people of all ages, all incomes, all levels of physical ability have what they need in their community. And that includes people from all racial groups, ethnic groups, and others as well. And it's important that taking a community by community approach to address these issues, we also must look within communities to see the different issues that people are facing. So as our recent study with Harvard University that looked at our livability index showed, we see people of different racial groups across the country in different types of neighborhoods at different livability levels. But the neighborhoods where African Americans are or other groups are sometimes different in the way that they're constructed in terms of livability, that they may not have the same access to healthcare or healthy foods and some of the other issues that may help keep people healthy, while their neighborhoods may have benefits and other factors, housing affordability and other housing kind of indicators, variety of housing options and the like. So in short, it's really important, and it's to our work, the idea that people have a range of different positive and negative factors in all of their communities. And if we're going to attack and address the ones that lead to these health disparities, we need to take a community by community approach and then look at all of those issues that are facing groups within those communities.
So I think that's exactly right. And when we look at the community level, I think that's very important. My report looked at the county level. I think the community level is where you see a lot of these disparities. And Courtney, I'm going to turn next to you. I actually did my internship and residency at UCSF at SF General, as it used to be called. Live walking distance from there, and being able to drive from the different hospitals. Even you could see the changes that occurred at San Francisco itself in terms of who lived where. Would you want to talk more about your work and the Health Atlas?
Yes, thank you so much for having me. I think the work that we've been leading at UCSF over the last 2 years, we're calling it the UCSF Population Health Data Initiative. And there are two components that I think are relevant for the conversation today. The first is the online tool that you just mentioned, Erwin, the UCSF Health Atlas, where we had taken the idea, at least across California, it's not a national tool, but focused specifically on California, all of the different available data sets that exist, from national data that we can pull from California, like the American Community Survey from the US Census, to more state-specific data, like the Cal EnviroScreen data that exists within our state, to think about environmental health risks. How could we pool those data and then put them up and use our health equity and our population health lens to think about the domains that would matter for people thinking about health equity questions and pull them into one website? So we had been working on that for a while, actually, before the pandemic hit, to think about what are the neighborhood level factors, the healthcare factors, the environmental factors, and those domains that we know are central to population health and health equity, and how would we visualize them on a website that would make it easy for people to go deeper and to explore those. And so we had come up with over 100 variables and a visualization scheme to show them at the census tract level and at the county level across California. And then the pandemic hit in March, and we were about to launch our website, and we made the decision that it was super important to add COVID data to our website. And we were able to do that by essentially reaching out to partners. And the same way we had thought about, there's these other data sets in California, we realized quickly that the LA Times was a major contributor of COVID data in the state of California, collecting the data from the independent county and local health departments. And so we were able to use open data from LA Times to populate on a daily and real-time basis the cases, the deaths, and the hospitalization rates of COVID across California. So we've been thinking a lot about that and specifically how the equity issues relate to COVID as an example. So all of the other domains that I mentioned, environmental health and neighborhood health, you can overlay that on the website thinking about COVID cases, or you can take any other lens. We're really trying to think flexibly about what your interests are and how you might use tools to go deeper. And that relates me to the second part of the Population Health Data Initiative that I think is relevant here. is that we really had imagined that researchers would want to use this tool. So probably many people in the audience of this conference, so people who were doing research, who were really familiar with their own data sets, right? Maybe they only used survey data mostly for their research, or they were only in electronic health record data, and trying to understand a single place that they could go that could convene the data for them to drive new research questions. So ours is only doing correlations, it's only at a high level of data, but you can download the data and use it. We would hope that more people would become interested in these place-based questions and think about combining of data. And we've been doing that with our own research projects on the second half of the Population Health Data Initiative to try to understand how we can link these data at the place-based level to our own electronic health record data to go deeper on aging questions. For example, we have a paper coming out on advanced care planning within the electronic health record and place-based disparities and differences in advanced care planning coming out. So how can we combine these data and get more people more interested in understanding of what's out there so that we can have more people thinking about these equity issues across our system?
And I like how you took the existing project and then modified it for the immediate need of the COVID-19 pandemic. And, Ali, I think there's a very similar story for IHME, which, I've always known you as having this immense data repository for mortality and the health adjusted life expectancy across the globe. But more recently with COVID-19, your organization has used that for modeling. But tell me more about this larger piece that you're better known for in terms of looking at geographic data and health.
Thanks. So we have been doing the global burden of disease for every country in the world and for many countries at the subnational level. So in the US, we do it at the state level. And then the data that you have shown on terms of change of life expectancy from 1980 to 2014, we looked at life expectancy at the county level. And we have in our states counties that have a life expectancy much higher than any country in the world, top countries in the world. And we have counties here where the life expectancy is similarly to what we see in Africa or in the Middle East, where I come from. And then when you look at the disparities between it in 1980 to 2014, the difference between the 1 percentile and the 99th percentile, it's increasing. So the disparities are increasing and not decreasing in the United States. And we, in our research, we tried to explain what's going on here. And briefly, there are 4 factors driving these disparities, socioeconomic factors that we need to address in this country. And we have, unfortunately, a sad history here when it comes to these factors. The second one is access to healthcare insurance. Many Americans don't have a health insurance, but also many Americans are underinsured. The third one is quality of medical care, and that's important. It's not medical errors. It's once you are in the medical system, how well you are being followed to make sure if you are on a medication for diabetes and blood pressure, you're getting the results that are intended by this medication, and to make sure we may have to change it. And that varies from a county to county. And the most important one, of course, are risk factors, and these are preventable risk factors. And in this country, we don't do a good job addressing them at the community level. In the bigger picture, where we take into account the socioeconomic, the environment, and the health issues when we address them that are in a way that are culturally sensitive. And in our research, which is very important to mention, that when you look at the county life expectancy, it's also misleading. So for many large counties in the United States, or even small counties in the United States, there are huge disparities within the county. So we've done this in King County, where we live here in Seattle. And by the way, King County is one of the rich counties in the United States. Boeing, Microsoft, Amazon, you name it. We have big companies here, and we have a good economy. But we have a life expectancy difference of 18 years between one census tract and another census tract. Then it begs the question in the United States that we spend almost half of what the world spends on health. What are we getting for it? And why aren't we addressing the root cause of these problems in our communities in order to extend life? And then there is another topic here about healthy life expectancy. You and I are talking about life expectancy. If you look at healthy life expectancy in the whole continent, we're from the bottom. West Virginia is number 3 from the bottom. So number three, even you take into account states in Mexico, states in Brazil. So we have a long way here in health, and we have to do it right, and we have to address the socioeconomic equity, and we have to, for sure, have universal health care for everybody here in this country. We're the only rich country that doesn't have that. Thank you.
Thank you, Ali. And so Roland, I'm going to turn to you. When I was at Johns Hopkins, you could see at the neighborhood level how sometimes where you're born and where you live can affect the rest of your life. Tell us more about your work at Johns Hopkins about on this issue.
Yeah, sure. So first of all, I said thank you, Erwin, to allow me to be on this stage with such esteemed guests and panelists. I've worked on a project when I was a postdoc. I worked on this project where we looked at people living under similar conditions. So myself and Dr. Thomas Levis had the idea of, we know health disparities exist, and what role does where you live play or social context play? And so we said we wanted to know a simple question: what is the nature of health disparities when people live under similar conditions? And so what we did was identified census tracts based on the three strict criteria of education at the census tract level, income at the census tract level, and then for it to be considered integrated, you had to be at least 35% white and Black, because we were looking at white and Black adults. And so what we found is that when people live under those similar conditions, that we found that we don't observe racial differences anymore in a lot of different health outcomes, particularly what we found in diabetes, health behaviors like drinking, smoking. We don't find the health disparities that typically observed when you don't account for the social environmental conditions for which people live. And so that to me was a huge finding, because if we can move away, and I think someone said this earlier, if we can move away from thinking about, is it a race difference? Because I don't know any intervention, a health promote strategy that could change us from being Black or white, unless we go back and redo the OMB definition, the socially constructed race, to do that. Otherwise, I don't think there's any intervention or health promote strategy we can do, but we certainly can change the social and environmental conditions people live in to make so that all people can achieve optimal health. And so we were very proud of that. But the one thing I want to note about that study, and the one caveat, it was that those census tracts were low-income urban census tracts. So we don't know if this is generalized to suburban areas or higher income tract areas. But the point is that we live in a highly segregated society anyway, right, for the most part. And so most of the time in our urban areas that we live in, you usually have this highly segregated areas that's overlaid with high concentration poverty. And what comes with the high concentration poverty, you get the poor housing, poor access to healthcare, poor educational systems for people who can't partake in private school. And that becomes a problem when we think in those terms. And so when we want to think about where we move now from what we learned there, we're thinking about how do we then try to approach many of these social determinants of health, how we try to see what we can learn about developing interventions to intervene on those, so that we can actually think about broad structures in which we can intervene to make change. Because the ultimate goal, I think, is for us to develop policies that fits for all people, so that we can have people age in place. And finally, I think one thing that has been inherent to all of the speakers' conversation, I just want to explicitly say it. When we think about this aging in place and how these things have occurred, they also give a historical context, and for a historical context for understanding where people lived before and where they are now, and how, if you move from maybe a place where you concentrated poverty to a place that you don't have concentrated poverty, what effects did those concentrated when you were living there? What effects, if any, may have transferred with you to where you are now that can impact your health and your aging process?
Roland, that reminds me when I was at Johns Hopkins working on the Baltimore Experience for a study, we were trying to recruit adults 55 and older to serve as mentors in the Baltimore City public school system. And AmeriCorps at that time required that all its mentors have a high school degree. And going back from 1990 and counting back to when our potential volunteers could have gotten that high school degree, and realizing that at the time they were growing up, there was only one high school in all of Baltimore that was even accepting, Black students. I mean, those are things I think that are critical, and understanding that past. Rodney, you have a question?
Yeah, I do. I actually want to follow up on that because, we have to bring the historical context in, and you just started to do that, Erwin. And, in 1910 or so, Baltimore was the first city in the country that established officially explicit racial zoning, right? And many different communities did that afterwards. And explicitly, so from the founding of our country until roughly 1968, it was legal to discriminate based on race. And in those years, it was incredibly encouraged. And so that zoning, those planning decisions, those policy decisions, those real estate decisions. I mean, back then, 1924, the real estate boards actually required a ethical realtor to discriminate in their practices. You could not introduce a race that might be undesirable, quote unquote, into other neighborhoods, right? So these are the times when these neighborhoods are being created and founded. And so we're creating these neighborhoods with the piled on economic disadvantage. And so there's not a level playing field to begin with, right? And so, we fast forward to today where we structure communities. I'm from Washington, D.C., where the entire eastern half of the region has many more African Americans than the western half to this very day. So that playing field at the start. And so now what we have are people that are making their best decisions on where to live and how to live their lives based on this playing field. So they may choose a neighborhood on the east or west side of whatever city they're in to try to live their best lives. But that the fact that we're kind of starting on this uneven ground with different neighborhoods having different kinds of amenities and deficits means that unlike the neighborhoods that Roland studied, people aren't starting from that even base. So we have to accommodate for that. We have to understand that if we're really going to try to understand and attack disparities.
And Rodney, yes, thanks. And we not only have to do that, we have to appreciate that it happened and also acknowledge that although it is illegal since '68, you still see the lingering effects in many of your urban segregated areas across the country where a lot of our older African Americans still live. And there's this lack of intergenerational transfer of wealth that goes back also. Why with those who could own a house, you had to buy it in other neighborhoods that were not were not as well. I said this way, we're more so in concentrated poverty, and that brings on other social and structural ills.
Yeah, I mean, even to your point, there was a Newsday article, I believe it was either last year or the year before, about Long Island. The huge discrimination that's happening there today.
Yes,
so it's maybe illegal, but it's still happening.
Right.
And having all of you here as experts in understanding geocoded data, sometimes we don't have the important data there, and that's why I think it's so exciting that many of you have been able to integrate various sources of data to sort of better understand this impact of racism and disparities on health as it's associated with where you're born and where you live. What have others found in looking at your data on this issue of disparities and racism and geographic disparities?
I don't know if others are using our data quite this way, but I think we've been thinking about our own data this way. So I can, speaking again sort of at the layer of the pandemic, which I think speaks to a lot of the structural issues that were just brought up. So it is a pandemic, but really it's uncovering a lot of other things that have been in place for decades and centuries in our country. When you think about COVID response and thinking locally at the local level about who's impacted, the same maps emerge, right? And the same kinds of things emerge. And I think in the way in which I've thought about the power of data like this is to help others not make the same maps over and over and over again for their projects, but to collectively think about what are we doing on the structural domain. So the healthcare systems being more engaged in place-based interventions with public health departments, thinking outside the silos of public health and healthcare into the other public policy domains to actually address some of the issues. And so for COVID, for example, when you think about the test positivity rate or the hospitalization rate, building an equity at a place-based level into how you look at that to ensure that a city or a county who's dealing with the pandemic is not simply testing a lot in certain neighborhoods or delivering vaccines when vaccine is available to certain neighborhoods, but actually is thinking about from the forefront of who needs the most resources and how communities have been impacted, so that you can actually make a change on something. So bringing resources to the communities that have been underserved structurally for a long time, like turning it around rather than creating maps and showing disparities is something that I'm interested in doing.
And Ali, I mean, you worked not only in the U.S. but across the globe on this issue, and thinking about the county level disparities, or even other examples of the work IHME does. How have you been able to sort of engage in this process of turning this data into addressing these disparities?
So in the United States, we have had a challenge, and we have been approaching the issue of race and racism slightly different. Right now, we're measuring racism by race as a proxy, and we know that's not the right way to do it. And unless we have a good metric for racism itself, it's not the skin color that makes you a disadvantage. It's your exposure and what has happened to you and your history. IHME is committed right now to move into that area and then put all our resources in order to be able to create a metric for racism. And like we do in smoking and lung cancer, have racism and other outcomes in this country, whether it is diseases or risk factors. And right now we've started doing some of this work. So let me give you briefly what we are doing in the light of COVID-19. One of them, we looked at education. And in this country, if you look at education disparities by race, not racism, by race, and all the way to high school, you see a great gap in years of schooling between African American, Hispanics, and white and Asian. If you look at learning, which is the national test of state tests, so not only years of schooling, learning, that disparity is much wider. And then we need to address, for example, education. And right now, schools get money from the county where you live. Why in this country don't we go and say that's the median for every school, how much money they get per head? And the government should kick in the rest of the money and make sure we have a good education to prepare the next generation to go up and get the higher education and the chances for employment. On the COVID front at IHME, we looked at the disparity by race within a state. And before COVID-19, African American had a higher rate of deaths, age standardized, compared to white. So if you have it on an x-axis, you'll see it clearly, African American, more likely to die, unfortunately, in this country. Add COVID-19 mortality to it, that disparity has increased. So they're even more affected with COVID-19. So they were at a disadvantage, and now they're even higher. If you look at Hispanics on the other end, Hispanics in many states, they were doing better than white. I mean, and we know that different reasons for Hispanics, and we're mixing Hispanics, young generation coming, healthy worker effect, and also Hispanics who've been here for a long time. Keep that in mind. But now it's even more devastating for Hispanic. That advantage is gone, and they're dying at a much higher rate. So what do we need to do in this country? I mean, we need to acknowledge the past and what we have done, and we have to move forward right now and focus on racism, on the experience that our minorities are getting in this country. And we have to address it from, again, socioeconomic factor, environment, and health. Unless we do so, COVID-19 has shown us that the health of our nation depends on the health of our weakest person in this country. And the people who are keeping food on my table, your table, and people who are keeping our country running right now, we need to protect them. And they happen to be people of color. I mean, this is a wake-up call for all of us. We have to do it right. As we roll out these stimulus, we have to do it right. We have a chance. We're borrowing money from our children and grandchildren. We have to do it right. We cannot leave anybody behind anymore. Over.
You know, and thinking about your work, Rodney, I mean, thinking about even just across life's course, Ali talked about education, and we talked about how workers who are people of color are being adversely affected by COVID-19. As we age, one of the things that we also looked at is how this, we know that there's going to be a differential impact for people who are older from COVID-19. your work looking at the neighborhood characteristics and thinking about how people the places that people live as they age. What have you learned from your work on this issue of disparities, and also the impact of race and racism?
Yeah, I mean, that's a great question. I'll tackle it in two ways. One is to even talk about the end of the life course. We're now seeing that different studies showing, and the numbers that keep evolving, but we do know that uh, nursing homes where African Americans are housed, are residing, are much more likely to have COVID cases than other nursing homes. So even in that phase of life, those things are happening. And to your point, Erwin, that gets to the life course of how these issues play out. So what this requires is an approach that takes into account these many factors. And frankly, one of the things that I'm optimistic about for 2020 is that many of these questions about the impacts of racism and race and racial disparities are much more out front than they have been in my lifetime. And so I'm hopeful that that will lead to examining more of these issues across that life course. And so that's one bit of optimism. Now, as we're looking at those, I tend to like approaches like the age-friendly network, the network of age-friendly states and communities, where a community enters this network with a promise to make things, to make their communities better for people of all ages. A mayor or county executive or what have you will make that pledge. And then they start a 5-year planning process. And that first year they spend in the community doing research. And the ones that do this successfully go to each part of the community, talk to different community groups through things like focus groups or meeting at a library in different parts of town. So you get to people in different types of neighborhoods and doing survey research, but getting at what are the problems on the north side of town and the south side of town and what have you. And understanding how those people are impacted differently and incorporating that into their planning process and then executing that over years to the following several years, and then reevaluating and seeing how that goes. I picked on urban planners earlier in Baltimore and other places in the early part of the last century. But in this century and moving forward, I think there's a great possibility to take these kinds of inclusive approaches, whether it's called social planning or inclusive planning or whatever you call it in your area or in your field, and include all parts of the community in this decision-making process. Know that we aren't starting from equal ground, but here are the things that we need to do to get to equity. I mean, all this whole conversation is about getting to equitable outcomes for folks. And so that does take a community by community approach. So hopefully people are going to be more upfront with understanding these issues, able to talk about them, and then actually attacking them.
Rod, I really like how your group has really worked on integrating what you've seen with other groups like the like urban planners, and others have done it as well. Ali, you just raise your hand. What are how would you like to follow up with that?
No, Rodney brought a very good point that we need to keep, reinforcing in this country. If you want change, long-lasting and meaningful change in a community, you need to involve the community. I mean, you have to have a participatory intervention in that community and work with them in order to make sure this is long-lasting. One thing I need to mention from IHME, right now we have a contract from NIH to do burden of disease at the county level by race, ethnicity, and socioeconomic status. And we have started preliminary analysis, and we have a working group with NIH and CDC. And we have seen a strong effect, of course, at the county level in terms of burden of disease by race. You would expect that. But it's surprising even for somebody like me who's been doing this kind of work for a long time. That's one. And the focus we would like to move into from IHME is not living longer. We all deserve to live longer and healthier. It's healthy life expectancy. And there are so much disparities in that regard as well, where people are living longer in the United States, but healthy life expectancy in general in the US is not catching up with the increase in life expectancy. And many people are left behind. And we need to address these issues at the community level. Over.
Ali, last time we met in person, it was at the National Academy of Medicine's Global Roadmap for Healthy Longevity at their inaugural workshop that we held at AARP. And we were talking about that. How does one measure healthy longevity? And I think the work that all of you do in looking at geographic outcomes may be helpful in that as well. And we thought about that when we thought about life expectancy age 50, but clearly it's not capturing health. Roland, you had also had a comment you wanted to make?
Yeah, I had a comment I want to make for a couple of people. I wanted to brag about Baltimore for one moment, because Rodney said something about nursing homes. In the midst of in the height of the first spike, when we first started, there's an all-Black nursing home in Baltimore, had no positive cases or deaths at hospitalizations at all. And I think about 2 months ago, that still was the case. So I don't know what they're doing, but many people may. And as you might imagine, Rodney, where it's situated, in what part of town it's situated, right? So they're doing something. I just want to acknowledge that they're doing some outstanding work. And I also wanted to piggyback off of what you said and what Ali said. I too am optimistic. And I too agree with you, Ali, that we need to do it at the community level. But I think it needs to be more nuanced. And I think people need to hear the nuances. First, we do need to think. I like this idea of the executive plan and strategic planning. But what we have to do, if we go into African-American communities, we have to build relationships. I don't want us to think that it's just we walk in and it's automatic. Many, because of the historical context of some of the African-American communities that have endured over the years. So we have to build trust. It's a trust building process over time. And I agree it's a decision-making process. And I also agree that strategic plan and reevaluation, I agree with all those things. But I think fundamentally at the bottom, it has to be some relationship building along the way so that we can have all parties involved. And the one thing I wanted to add on to the outstanding comments that Rodney made is that the one thing I think that we haven't said directly, I don't want to say it now, we're going to need policymakers to be involved. We haven't explicitly said we need policymakers, and we need those people we need to employ political determinants of health, right? For those people who we need to think about those places and those environments, who are the people that represent them? And if they're not representing them, maybe we need to go about change through the voting process, right? Which is one area. But I do think that we need to think about policy and health in all policies. I think that's a big issue of the problem that we've had before. We think about health policies in one place, social policies in another place. When in fact, when you're thinking about health or trying to achieve health equity, it's the synergistic effect of all of them together. And I'll stop right there because I want to hear what Ali had to say. And I know Courtney has been shaking her head. I'm excited to hear about what she has to say.
No, I totally agree. It takes a village. I totally agree. We need there is no silver bullet here. We need a comprehensive approach that involves everybody. Unless all of us do our part, it's not going to work. Policy all the way from policy. But the other point also that we forget in this country, we don't have this concept of health promoter, people from the community working on health promotion in their own community. If you travel everywhere in the world, you see it. I mean, you go all South America, you go to a remote village out of nowhere, there is somebody employed by the Ministry of Health or the local health authority who is a health promoter. You meet with the health promoter, you say, who's pregnant, needs so and so. She will point you or he will point you to that person. We need at the community here to hire people from this community who understand the community, who are our liaison in order to build that trust that you are talking about. I totally agree with you. We have a long way to go, but I'm very optimistic, and I hope COVID-19 was a wake-up call for all of us, but we have a chance to do it right. And it shouldn't be like what we have seen throughout history. I've been in this country for a long time. We debate health more than anybody else. We talk about it more than anybody else in the world, and look at our health outcomes. It's time to do it and do it right.
Now, Courtney, I want to give you a chance. I also want to sort of ask all of you, I think what's really fantastic about the work you all do with neighborhoods and projecting that information onto maps. Some people have difficulty reading figures and graphs. So maps, there's something very approachable about that. I mean, as we sort of take this issue of race and racism and make sure that it's integrated into community planning, that communities are integrated into themselves, are integrated into planning, how can we use this idea of maps and geographic information to help with that? But Courtney, I want you to be able to add your voice to this.
Yeah, I think I'm going to touch on the map part of it. I think that's what I said earlier in terms of, we thought of researchers as our primary audience, but I actually think visualizations help everybody understand priority areas at a high level. And then I wanted to really echo the point of the local knowledge. It will never replace the local knowledge. So even if you can make data available and get people aligned across public sector domains, community-based organizations and community leaders who live in that neighborhood are probably the only people who can tell you which to do first, right? There are multiple structural domains that are impacting how people live and their health, but is transportation the thing that we across those, we have to make progress. And then there's those decisions about how to work on them and how to work on them in tandem and in a concerted way. And I think it's the local community-based organizations and my other stream of work that they can help. They already have the advocacy and the prioritization that we are not tapping into their expertise, in my opinion. And then the last thing I wanted to say was, I think the healthcare system is a great point that Ali brought up, which is that the incentives have been so misaligned, right? I think part of the issue is in public health, we've known this for a long time and we've been trying to talk about it, but it's chronically underfunded in the way in which we think about health. And healthcare systems have had a lot more resources, but have been newer to this population level view of their data and who their members are and how they think about it. And that's where I think our own healthcare Department of Public Health in San Francisco knows a lot about parks and interventions at the population level, but actually doesn't know about diabetes at a census tract level in the city and county of San Francisco, because that data sits in the electronic health records of the healthcare system, right? And I think in order to do this, to your visualization point, I really think we need to be rethinking how we work together. And then the resources are a big issue. Like, how do we distribute the resources to actually do these structural changes moving forward in a different way?
And also bringing that data out so the people in the community, in their own communities, can understand that. We have like 5 minutes left. I'm gonna go around, and Rodney, do you want to go next? And
sure, I absolutely do. And because I want to build off your question about maps, but first to Roland's point, it was, I believe, the Maryland Baptist Aged Home. So I don't want to pick on Baltimore too much. I want to say that I appreciate they're doing great work, but also in that example is one where despite the fact that we're talking about these overall disparities, it doesn't mean that all African-American nursing homes are in trouble. It's a great example that we can do things if we target a particular population and work there to overcome the obstacles that are there. So I did want to say that. And to your question about maps, Erwin, and showing things, one of the things that was behind our creation of the Livability Index, which at the time was the world's first neighborhood-based nationwide livability index, was the idea that we could use a map to bring together all of the different things that go into livability, these 7 categories and 40 metrics and 20 policies that we measure. The idea that looking at all those things comprehensively was something that was very difficult for people to do and understand, policymakers, residents, and others. So bringing them together and overlaying them visually is a way to really help people understand that, their housing cost and their transportation access and their proximity to things in their neighborhood and their healthcare access, those are all things that are connected and impact their quality of life. And so understanding those trade-offs and frankly, attacking the silos between the government agencies that work on those issues, I think is the single biggest policy problem that America can tackle. Eliminating these silos and understanding the interconnectedness between these issues will take us a long way to actually being able to solve and address these problems in the future. So it's something I hope that we could get to.
Before I go to Courtney, I just wanted to say also, Rodney, I think what's really exciting is that you've taken this livability index and then you've worked, with the paper with the October 30th release, and looking at issues of race and adding that to your geographic data. I think is very exciting. And it's about integrating this issue of race and ethnicity and racism into all of our conversations. I think that's going to be an important part of this.
Yeah, I understand it. Yeah.
Tell me a little bit about, in terms of things that you're doing and also how you are using maps to affect policymakers.
Yeah, I think the COVID example of how we put it on our map is probably the best example of how we've been working with policymakers to visualize what's happening at a local level. And I think in terms of the sort of the second part of where you're going, Erwin, like what we can do next is I really feel like I wanted to follow up with all the people on this panel to see if I can add some of these AARP variables or some of these other racism variables that might be coming out from IHME, because to me, overlaying the maps at a local level, it unlocks the power for people to understand priorities. And so I would say, I just put a call out there that we're really thinking hard about health. We would love to add more aging specific variables and specifically more social and structural variables to our maps to break down those silos across the social service domains into one place for people to really understand how these things intersect, so that we're not, again, continuing to make the same conversation, but actually thinking differently about interventions.
And I would love to have a follow-up conversation as well, because I think having this data accessible to people in the community is potentially an empowerment tool, and that's what maps can do. Ali, why don't you go ahead?
So briefly, we need, with all the science that we are doing, we need a better communication, and that communication should be at different levels. So basically, you want to provide the information for policymakers, our peers, journalists, family. You want on your web, somebody can go and say, I'm a mom, and then the information relevant for her or for action should be available. So we need to do a good job about getting our research and taking it, not from publishing a paper, so what and how could be applied. The second thing in this country, we need to start focusing on human capital. We publish Human Capital Index, which is an index of health and education. If we want our country to develop economically and we stay at the edge of science and development in this country, we have to invest in our working force, healthier, and their education. We need to start talking money and how much not investing in health and education is setting us back as a country. And the third one, we really need to do a better job of examining where success has happened against all odds. There's certain communities here, African American or Hispanic, where we have seen change and we have seen progress. We need to go there and find out what's happening. And the reverse, where we have seen a going backward and why, we need to understand it, perhaps sharing lesson across, again, being sensitive to the culture and involving the community.
Ali, I really like that what you said about affecting the life course. And that's something that having data for people, the data that people need at the moment of their lives when they need it. Roland, I'm going to let you have the last word.
So I just like to, I want to comment on something Courtney said, and I'd love to reach out to you afterwards. Dr. Sarah Zanton and I just received some NIA funding, leadership award to develop a tool of structural discrimination with individual level discrimination. The problem is that we oftentimes separate them, and we're trying to create a tool that have them both in one. And our goal is to do that over the next 3 to 4 years, and then be able to put this in the public domain for use. I think I just want to speak to this issue of maps real quick. I think I agree with what all the panelists have said today, and I just want to summarize my point of view is that I think these maps are incredibly important, because when we're talking to stakeholders and policy people, no one wants to read the articles. You probably don't have access to the articles because you don't have the subscriptions to the libraries like we do, and nobody's going to pay $40 for that one article by Roland Thorpe. They could care less, right? So, but what you want to do is you want to get information in a way that's digestible using maps, infographics that tell a small, simple story. So if they have to articulate that story to their constituent or articulate it for policy, they can articulate it in a meaningful way. And we need to work with them to develop policy briefs so that our points are not lost. And we need to come to the table and understand, hey, how can we write this in a term where everybody can have it? And we need to get the information, Ali, I believe we need to get information back into the community in a way in which the community can do it, can use it in the most meaningful way. So I do agree with you, effective communication at all levels.
This has been a great conversation. Thank you all for joining us for this part of it. Looking really forward to the next section with some questions. And when I talked to Karen Tracy from GSA about this, I told her this was going to be a fantastic panel. It has been. Thank you very much. And let's transition now.
Thank you.
Thanks, everyone.
Hi, I want to thank everyone in the audience for joining us here now for the live session of the GSA Momentum session. I'm here with Dr. Rodney Harrell. Rodney, I really am excited to continue this conversation, especially as it relates to the issue of housing, because I think central to all the conversations we've had is the idea of home and where you live, and piecing in the historical issues of redlining, of systemic racism, and thinking about how you and your livability index talk about housing livability. How do you categorize housing livability within your index?
Yeah, that's a great question, Erwin. And I think it starts with this. We need to have an understanding of community, that housing and homes are part of community, and we all live in our communities. And so one of the things that we do with the Livability Index is we combine housing with 6 other categories so that we can give you a neighborhood score to really understand all the components that go in there. Now, we have a specific housing category that looks at housing cost, whether there's accessible housing, whether there's different options for housing, whether there's perhaps even subsidized housing in your neighborhood, and whether there's housing with accessibility features. We look at all of those things to look at the house itself, the choice in housing. But the way the index works is we connect that with the other 6 categories, because frankly, if your home is affordable, but it's not near anything, if it's not near any parks or libraries or jobs, or if it's unsafe, if there's environmental hazards, if there's no opportunity there, those are problems as well. So the idea is that we have tied together housing and housing costs with all of these other factors that people need, really getting at that silo problem I talked about, that housing doesn't exist in a bubble, is our way of thinking about it.
And I think that's important. This relates to a question that we're actually getting from one of the audience members, because when people think of housing, they think of like how a realtor might define, livability, but you're talking about livability across the lifespan. So there's a question about, I'm curious that how do researchers talk about disparities issues corresponding to geographic data without putting a stigma on the people who live there? In my country, once a city was mapped with hotspots for domestic violence risk by using administrative data and was criticized for accusing people who live there for having a violent tendency. How do we as researchers avoid the situation in connecting geographic data and social issues?
That's a great question. And the first part of that is to be aware of it. The same as with all other biases and other issues that we may face, we need to be aware of our own biases and those, frankly, of the audience that might be receiving the work that we're doing. Our approach with the Livability Index on that was to focus on the places, not the people. And by doing an index that focuses on the geography, how many housing options and parks are in this neighborhood, that kind of approach takes the people out of it for a second to understand on a level playing field what's going on and what's happening. Now, I think it's important to then put the people back in to understand, if there is a certain population, a certain group of folks that aren't getting access to healthcare or some other thing in the community, we need to know and be aware of that. And I think frankly, it's the convenient thing of our inconvenient history on racial issues is that people live in different places. And so you can certainly tell in what the African-American neighborhoods are facing, or the Latino neighborhoods, or neighborhoods where certain other groups of people are in your community, what they're facing compared to other neighborhoods and other people in those neighborhoods. So for me, really being able to look at those things independently and together is key. And so we may need to look at just purely objectively, why is it that this side of town has no access to exercise opportunities or grocery stores? Why is that not happening? That's the way to, for me at least, to look at not putting stigma on the people that live there. But your approaches may vary depending on the kind of work that you're doing.
And this, I think, leads to another question that we got from the audience about what are ways you could suggest supporting policy changes that increase the perspective of health in all policy. And I think one of the things that was really rich about our conversation is to see how health was very much integrated into issues of place, of housing, of and all the things that you describe in your livability index. One of the questions I also had is, thinking about the report that I was a part of in terms of county level data, and then the data that you have that's really much very much at a neighborhood level. How can these two sort of levels of analysis add to a conversation that helps move us forward in terms of how county level issues and neighborhood issues can lead to disparities and how we can potentially address them as well?
Great questions. So first, I'd say that I, as an urban planner, as a policy person, I've been very excited to see in the past few years that the folks in our health friends on that side of the aisle have started to look at the idea of social determinants of health and health in all policy kinds of discussions. And what that does to me, it does the equivalent of just good planning by noting that things like our housing, our transportation access, our access to care, all of those things are part of keeping people healthy. Access to healthy foods, many more things are all connected there. And so the idea to me is that we understand, if we are using a health lens, we understand how all of those things in neighborhoods interplay with one another and can impact our health. So if we're starting at a health outcome standpoint, we need to think about all those things that are going into that. If those people are next to a highway, if they can't walk and do exercise, if they can't get healthy food, it's not surprising that that same area might be suffering when coronavirus or something else might happen that becomes a health issue. So that's very important. And to your second point about levels, looking at levels of analysis, I look at your recent study and our recent study with the Harvard Joint Center as two great pieces of a puzzle. Because what we need to do is, and your study looks at overall, let's look at the country and look at different groups. What are they facing in terms of their health status and this particular disease it impacts? So let's unpack that at a national level and understand what different groups are facing. That's crucially important to understand what's facing a certain group. But then the kind of analysis that we did with the Harvard Joint Center looks at what's going on the ground in different neighborhoods, in different places that people are seeing. Every neighborhood's different. It's a different set of circumstances. But then by looking at that level, you can aggregate larger and see patterns of things that are happening. I often say this. In past years and centuries, we had to keep things simple. We had to just look at one factor. We had to look at that in one way and come up with whatever analysis we could. The scientific method tells us to take some problem, take one experiment, look at it and see what that results in. But in 2020, I think we're in a different place societally and scientifically. We need to take different approaches at a problem if we are to fully understand it. And so I love looking at those many levels. Let's look at the national level. Let's look at these subgroups, subpopulation groups, and let's look neighborhood by neighborhood. That's going to help us get the true answer.
You mentioned 2020. And I think about how COVID-19 has affected my view of healthy longevity. There was a narrative how we as a country, as a globe, have really sort of tackled infectious disease, and now we're talking about chronic diseases. And now healthy longevity makes us realize that those chronic diseases are now affecting our risk for an infectious disease. How has COVID-19 changed the definition of livability in terms of elevating certain issues that people now face with COVID-19?
Well, from my point of view, COVID-19 has drawn attention to some very important things. It's drawn this disparities conversation into more of a national spotlight. So the disparities that have been there for years and that we've been discussing for this last hour are there. And the fact that we're now understanding that does have these health impacts. The way this disease plays out is different in different communities. It's drawing more of a spotlight and giving more of an opportunity to talk about these things. And what I'm hopeful is that it then leads to more enthusiasm to start to look at some of those underlying causes and root causes of these disparities in the first place. It's still too early to see if that's going to happen, but I'm encouraged and buoyed by the fact that many people are still thinking about these issues, and they're still in the popular discourse, and they're on people's minds when you see these polls on TV. So I'm hopeful that COVID becomes this national reckoning of how we work with a pandemic and many of those direct issues that are often talked about, but also some of the impacts, those social impacts, the housing impacts, the economic impacts of what's happening when we see something like this occur. I'm optimistic that that's one of the silver linings that we're going to see.
I'm hopeful too as well. I think there's this opportunity for us to not go back to 2019, but to really think about a reset. Thinking forward to next year's GSA meeting, a new normal, and helping us all work on a new normal that's more equitable. So I'm really excited about that conversation we can have next year.
Absolutely.
Talking about the future, we're going to be releasing additional data at the state level and looking at how geographic disparities can be influenced by in terms of other communities, including Latino communities and in some states, Asian American communities and Native American communities as well. tell me a little bit about your work as we close out this momentum session. What are you planning to do in the future?
Well, one of the things our team is working hard on right now is an update to the Livability Index that we'll hopefully have sometime in next year that will give us another glance at what's going on across the country to give that comparison. And my hope is that helps us as we start to look more at some of the housing issues that are impacting people of all ages. And I think it's societally, I think it's important that we look at not only what policymakers and people that our community leaders are doing. We need to look at what the marketplace is doing to help support people and give them the options. And we need to look at what individuals are doing and give them the information they need to make better choices. And we know that the vast majority of older adults want to stay in their homes and communities. It's over 60% of those 50 plus, and it gets higher and higher as you go up the age range. And yet we know that there are these gaps that either prevent them from doing so or force them to compromise. And so I think a lot of our work will be to highlight those gaps and highlight solutions for those gaps so that people can live their best lives as they age. They can do what they choose. And frankly, you can have more choices so that you can find that best place to live for you and your family.
And that's what I think is going to be very important as we go forward, thinking about, as our CEO, Joanne Jenkins, likes to talk about the personal, the public, and the private, right? And having the various sectors work together. And I think what you do with housing and neighborhoods really give us an opportunity to look at all three of those lenses through those three things, the personal, the public, and the private. I think our time is up. I really have enjoyed talking with you and seeing your face. And I'm really looking forward to next year's conversation at GSA, talking about this new normal and maybe even seeing where we've all moved with this issue of disparity. So Rodney, thank you very much. I want to thank James Appleby and the rest of GSA for taking this time to invite us to speak. And I want to thank you and the audience. Thank you for joining us. Please, everyone, stay safe.